Good morning, everyone. Welcome to today's Grand Rounds. My name is Alex Harris, and I'm one of the Grand Rounds co-directors, along with Drs. Rebecca Muley and Adi Talati. If you want to contact us to meet with one of the upcoming speakers or to suggest a speaker, please write to us at grandrounds@nisbe.columbia.edu. Next week's Grand Rounds, March 27th, will be presented in person by Dr. Catherine Keyes, Professor of Epidemiology at Columbia University. The title of her talk will be Suicide Clusters, Spatial and Temporal Correlations and Their Environmental and Social Determinants in the United States, Leveraging Novel Methods for Prevention and Intervention. Before we introduce today's speaker, I want to encourage everyone joining us to post questions at any time during the talk using the Q&A feature in the bottom of the Zoom window, which is separate from the chat. If you are a trainee, please put the word trainee at the beginning of your question, as we would like to prioritize trainee questions both online and in person. Please also write "Can ask question myself" at the end of your question if you wish to ask your question yourself, which we strongly encourage you to do. We will then temporarily promote you to panelist so you can ask your question directly to our speaker. Today's Grand Rounds is the Women in Sciences Empowerment or WISE lecture given by Dr. Neill Epperson. I'm going to call on 3 of our faculty to present the WISE lecture. So the first is Dr. Danny Dumitriou, a pediatrician and neuroscientist with dual appointments in pediatrics and psychiatry. Her research program spans preclinical and clinical models with the mission to uncover and harness principles of health and resilience using a cross-species, multi-scale, multimodal approach. Dr. Stephanie Collins-Reeds is an assistant professor in the Substance Use Disorders Division. She uses preclinical and clinical human models to examine sex differences and women's health issues in a number of different vulnerable populations, including users of stimulants, alcohol, and cannabis. And finally, Dr. Weili Cheng is an assistant professor and physician scientist in the Systems Neuroscience Division. She uses mouse models to study hippocampal circuitry, specifically how these circuits are altered after early life adversity, and how plasticity and pattern separation can be enhanced as a strategy for treatment in mood, anxiety, and cognitive disorders. Please come up.
Hi, everyone. It's such a pleasure to host this lecture. This is our second WISE lecture. And I'm going to start by giving you an intuitive feel for why we have the WISE initiative in this department. Advancement work? Okay. Perhaps I can. There we go. We are working the magic. Perfect. Thank you so much. So to give you an intuitive feel, this is a representative slide for female professors that start out as assistant professors in any STEM field in the United States. I've pulled data here from a bunch of different sources, but roughly 50%. By the time they get to associate professor, not too much of a drop-off, perhaps about 45%. By the time they get to full professors, however, we have about a third representation in terms of women in STEM fields. And importantly for today's speaker, by the time they get to department chairs, we have a huge drop-off to somewhere between 14 and 25%, depending on the field. So that is why we formed the WISE initiative. The 3 of us co-chairs, myself, Dr. Weili Cheng, and Dr. Stephanie Collins-Reed. We started this actually in 2020 as an initiative that was supposed to have our very first meeting on March 7, 2020. As you can imagine, that had to be canceled. We initially were very resistant to starting this over Zoom because the whole point of this was to really create this tight-knit community. But we ultimately decided that we had to go via Zoom. So we started up in October 2021. We do a lot of really interesting topics. We have, for example, departmental topics on academic promotion. So Abby Fire and Scott Stroop have talked to us about promotions. Blair Simpson has talked to us about the state of the department. Ann Taylor has given us an institutional perspective. We also have informative lectures, for example, by Katie Sharkey, Associate Dean of Equity and Diversity at Brown University on achieving equity. We've had Tali Baram from UC Irvine talk to us about a small woman's guide to academic galaxies. But more importantly, we're actually a really fun group and we have a lot of really fun activities. So we have, for example, get-togethers here in the building, but also an annual reception now at the faculty club on the Morningside campus. Last a year ago, a little over a year ago in December of 2022, we hosted our very first one, and we had the incredible honor to have Susanna Cahalan, New York Times bestselling author of Brain on Fire, be our guest. And we will have our next one and on May 16th, 2024, so this year. And we have the great privilege to have a repeat of a female comedian, Periel Ashenbrand, who's really hilarious. We hosted her initially over Zoom, and now we will see her in person this year. So join us if you're faculty affiliated with the Department of Psychiatry. We are also trying to now go outside of the department to really include more women who work on any kind of brain, neuroscience, psychiatry, psychology, or any of the related fields. Thank you.
Okay. So, hi everyone, I'm Wei Li Chang. So it is my distinct honor to introduce Dr. Neill Epperson. She is a professor and the Robert Freedman Endowed Chair of the Department of Psychiatry at the University of Colorado School of Medicine, Anschutz Medical Campus. She's also the executive director of the Helen E. and Arthur Johnson Depression Center. And before being recruited to CU Anschutz, Dr. Epperson served as the founder and director of both the Penn Center for Women's Behavioral Wellness and Penn Promotes research on sex and gender in health at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia. She was a tenured professor there with a secondary appointment in OB-GYN, and she received her medical degree at UNC Chapel Hill and completed her postdoctoral and research training in psychiatry at Yale University of Medicine in New Haven, Connecticut. She rose to the level of associate professor there before being recruited to Penn in 2009, and then was recruited to Colorado as chair 5 years ago. She's internationally known for her unique lifespan approach to women's productive and behavioral health in her clinical, teaching, leadership, and scholarly endeavors. Her body of research has led to a greater appreciation of the impact of gonadal steroids on brain structure and function, and the importance of considering reproductive status and sex in all biomedical research. She's demonstrated in her research that childhood adversity has an enduring impact on physiologic responses during times of hormonal fluctuations, as well as gonadal steroid effects on brain and behavior. So she has been consistently funded for over 2 decades. She has mentored countless students, postdocs, junior faculty now as chair, and she's widely respected and regarded in the field. So we're so happy that she came as our guest speaker this year. So please join me in welcoming Dr. Epperson.
Thank you so much for that kind introduction. And it's good to see folks here. I recognize that a lot of people are on Zoom. And so we certainly, if anybody on Zoom has trouble seeing slides or hearing me, please feel free to let someone know so that you can be a part of this. All right. So does this work? This works. Okay. Nope. Does not. Nope, it does. So going back to that slide, how many of you have actually had brain fog at some point in your life? Okay. A lot of women complain about this. A lot of women complain about brain fog, particularly in the after surgical menopause with chemotherapy, if they've had gynecologic or breast cancer, often, even with natural menopause. And so, but I know a lot of people who also complain of baby brain, after delivery. And I had a mind like a steel trap until I had my first child. And then all of a sudden it was like I couldn't remember anything about any of my research participants. So in any case, it is a phenomenon. It's kind of a non-distinct way of talking about cognitive difficulties. And I basically believe that it's something that we need to consider across a lifespan. And I got very interested in how early life adversity could potentially lead women during the perimenopause to experience more or less executive functioning difficulties in particular. And so we're going to talk about that. But I did add a little bit about perinatal mental health and perinatal work that we've done, also focusing on how childhood diversity can have this enduring impact. These are some of my disclosures, but I have to say my primary disclosure is that I think the brain is the most interesting organ in the body. I hope that because you're here, you have a very similar opinion about the brain. You should love it. I think it's so critical that one of the reasons I became a chair is because my career mission has been to promote the centrality of the brain with respect to all areas of health. And being able to be a chair and meeting with people from other fields of medicine, I get to constantly remind people that whatever they're most interested in, I can be a little bit of a pain too when I do this, whatever they're interested in, whether it's multiple sclerosis or renal disease or cancer, that they can't forget the brain, that the brain is impacted by all of these other medical issues, and that they need to consider that because the brain is always the last organ that they think about. All right. So my research portfolio has spanned pretty much the entire female lifespan. I started out in perinatal mental health with a focus on what happens to women in pregnancy and postpartum, moved into focusing on premenstrual dysphoric disorder, and then I've been really recently focusing a lot on sort of the peri and postmenopause. Again, I'm married to a child psychiatrist, and I started focusing on, gonadal steroid effects on the brain. And he's like, Neill, you really have to consider childhood adversity because it's going to impact everything that you're looking at. And he was not wrong. So I moved into focusing on childhood diversity and its impact at these times of reproductive change. Sex differences became something that I was very interested in because I felt like in order to improve women's health, I needed to also study men. I'm not going to talk about men here, but we have several projects focusing on issues of stress and early life stress in men, and then intergenerational transmission of risk and resilience. So how does a mother's childhood adversity history impact her offspring? So I'm going to talk a little bit about adverse childhood experiences. Basically, we use the ACE questionnaire, and people can argue with me about why we use this. I'm going to explain a little bit. You might not be convinced, but basically, it's a 10-item questionnaire that has a lot of data behind it to show that the more of these adverse childhood experiences someone reports, the more likely they are to have various chronic medical conditions as well as behaviors that lead to poor health outcomes. The ACE questionnaire tends to say, the people who've studied ACEs will often look and say, well, if the risk category is having 4 or more of these ACEs. But what we did is we did a sensitivity analysis in all of our studies, and we found that when it came to the reproductive time points that we were looking at, having 2 or more adverse childhood experiences is sufficient to infer risk. And I will show you some data that we have recently that's under re-review at a prominent journal that I can't name. But in any case, even having 1 or more if it's timed in the prepubertal window. So basically, the ACE questionnaire asks 3 questions about abuse, 2 about neglect, and 5 questions about sort of just the state of the household. Mental health problems, is a family member in prison, did you witness domestic violence, and things like that. So this is one of the main reasons why I fell in love with the ACE questionnaire, is because hundreds of thousands of people all across the United States have completed some version of this questionnaire. And these data are from the CDC website. All you have to do is CDC and ACE. And this psychedelic map is to basically show that between 2009 and 2020, how many states actually gave the ACE questionnaire and in what year. And even though we just passed legislation to create these psychedelic wellness centers, I'm really ashamed to say that Colorado it's in orange. It doesn't have all these really fun colors. It's just orange because we've only given the instrument once in 2014. But basically what this allows us to do is to say, okay, what is the prevalence of these adverse childhood experiences? Again, somewhat limited, but still. and across the country. And if you look at more populated states like New Jersey and New York, only about 3% of the population reports 4 or more of these ACEs. And again, this is who was surveyed. I'm sure there are a lot of people in New York and New Jersey that have more than 4 ACEs. But of the people surveyed, and again, these are typically telephone surveys, and you see that only 3%, but in more rural states like Oklahoma, Montana, and West Virginia, you get up to 12% reporting 4 or more. And the thing that is important for this lecture is that females are overly represented in the group of people who report 4 or more of these adverse childhood experiences, almost twice the amount of females compared to males. So people always ask me, okay, you know, a lot of this happened, and some of it I'm going to talk about is prepubertal when it happened. How in the world does childhood adversity kind of have this enduring impact on people decades later? And when I get to menopause, I'm really talking about 40 and 50 years earlier that these experiences happen. And we know from animal studies as well as some human studies, there's alterations in gene expression. I've highlighted here brain structure and function because I am going to talk a little bit about that at the end of the talk. Stress responsiveness, so how people respond, their HPA axis responds to stress, how their immune system responds, their autonomic nervous system, the microbiome. There's plenty of studies that have shown that adverse childhood experiences has an impact or is associated with a suboptimal microbiome. Again, we can argue about why that's happening, but also response to hormonal dynamics. And again, I'm going to show you that at the end. So we know that stress impacts people all across the lifespan. And I'm just going to start by focusing on how stress that occurs in the prepubertal window is impacting women in the during pregnancy and postpartum. So we did a study where we recruited from Philadelphia, and I try to highlight people that have worked with us. Debbie Kim is one of the investigators. Eileen Wong is OBGYN, and Lise Hansu is now an assistant professor at Hopkins. But we decided that we could do 3D ultrasound looking at the fetal adrenal as a proxy for what we think is happening across development. Again, you know, you have to use whatever you can as a proxy in a human study. I envy my colleagues who do basic science research because they can actually get mechanistic. So this is very descriptive, and a lot of my talk is going to have that one particular flaw. But in any case, we were using sort of fetal adrenal volume about mid-second trimester, and looking at the volume in a group of women, fetuses of a group of women who had high levels of ACEs, so that meant 2 or more adverse childhood experiences, and then those that had 0 or 1. And we had an a priori hypothesis because there's some data suggesting that particularly distress during pregnancy has more of an impact on the male fetus than the female fetus. So we had an a priori hypothesis that we would see a greater effect even during in utero life on the male fetus. And that is exactly what we found. And these are some other colleagues that have been involved in this work. Karina Duffy is the senior author on this, or first author on this paper. So basically, if you see here female and male, you have the low ACE females, high ACE females, no particular difference in fetal adrenal volume. And this is weight adjusted because baby boys do have larger volumes by and large. But what we see here is that I mean, and I hate to use this term feminization, but so we won't, but I do know that sometimes people use that terminology. That bottom line is that you see the biggest effect in the male group, that the male fetus of a high ACE mom has a smaller fetal adrenal volume. So that suggests that something is going on during gestation that is impacting the HPA axis. We've also studied moms in the postpartum period and their offspring. So, and in this study, we were able to add a mouse model. So let me take you through the human model first, and then I'll explain the mouse. So basically, we took the same moms that we did all that fetal adrenal work, put them into a room, basically had them rest and have their babies with them, and we started a salivary cortisol collection. Then we basically assessed mom's cortisol and baby cortisol after baby was taken from mom and baby was undergoing a stress test. So the babies had a sort of full-blown stress test. The reason why we started studying moms in this situation is because my research coordinators, and you should always listen to your research coordinators because they're the boot on the ground. They're the one that is there taking the baby from the mom. And they basically said in one of our meetings with Tracy Bale, and this is the benefit too, I'll get on my soapbox, of having center grants that support basic science research and clinical research that is sort of hopefully reflecting sort of the whole translational continuum. And so in any case, the research coordinators were sitting there with myself and our basic scientist, Tracy Bale, and her postdoc at the time, Katie Morrison. And they said, we can tell which moms are the highest moms and which moms are the lowest moms. And we said, how do you tell that? And they said, well, because our highest moms will basically give us the baby and not ask very many questions. The moms that only have 0 or 1 are very anxious about us taking the baby from them. And they ask lots of questions. And I'm like, oh, that's really interesting. We think that this is a maternal relevant stress test. So you take something that is a normal maternal behavior, and in mice can't stand to be separated from their offspring. They go nuts, And so we basically said, okay, let's study the moms now, in addition to the babies. And then Tracy's postdoc said, but I can create a mouse model for this. And so the mouse model here was, you take these moms, you give them peripubertal stress. So it's a 2-week chronic variable stress model. And you have some that are stressed and some that are control moms. You separate them with a permeable barrier so that they can hear their pups, they can smell their pups, and they can hear the ultrasonic sounds that the rat pups make or the mouse pups make. So the female mouse should go nuts. I mean, she's traveling around trying to get, because that's what they really want. They want to get to the mice and bring them back to the nest. And they were measuring corticosterone in this, as well as how much they worked to get to their mice. And what you see here as far as area under the curve with respect to the more that the control mice, so the non-stressed mice, basically they have higher levels of cortisol, they go up, and they basically move around a lot more to try and get to the mouse. Whereas just the opposite is happening in our high ACE moms. So the moms with more adversity, they basically make over time less corticosterone, and they travel and they start to give up more quickly at getting to their mice. So what did we find in humans? Well, what we found in humans is that our moms with you guys can see this. Moms with the highest group, they had a dampened cortisol response to the stressor. And here in the low ACE moms, you see this nice increase. So we were able to show here a difference in the mouse and in the human. And obviously in the human, no human is going to allow you to take a piece of their brain. Obviously the benefit of being able to have this preclinical model is that Tracy and Katie were able to show that there was upregulation of certain genes that are impacting the HPA axis of the mouse in these peripubertally stressed mice, so that there was this enduring effect of this earlier stress in life on genetic expression of, again, genes, particularly a fair number of immediate early genes that were really going to focus on the HPA axis regulation. So again, suggesting that there's an enduring effect. So what does prepubertal abuse, because a lot of times people say, okay, that's great, you lumped all the ACEs together. Let's look at, tell me that abuse is the same thing as witnessing domestic violence or having a parent be divorced. And so what we did, once we got a larger sample, and this is the paper that's under review, we basically tore it apart a little bit, the ACE questionnaire, and we basically said we wanted to compare different groups. We wanted to compare if a mom, there were 3 groups, women with no ACEs, and then, or no prepubertal ACEs, and then women who suffered a prepubertal ACE that was abuse, or a prepubertal ACE that was not abuse. And what you can see if you compare the 2 abuse groups with those that had no ACEs, that you have a dampened cortisol response that is significantly different. than that of those that are in the 0 ACE group. But that whether that one ACE was abuse or not abuse, that group did not look different from each other. And I know that that flies in the face of what everybody believes. And so it is important that we say that, one, if you've got abuse, yes, abuse is a very pernicious and horrible thing that happens, but there's something about prepubertal onset of adversity, even if it's not abuse, that has a tremendous impact on postpartum cortisol response to the stressor. And then what we wanted to know, and again, this is a sex differences approach, we didn't see any differences between the males and females with respect to cortisol response. And these are the babies at 6 months of age. We didn't see any difference if they were in the low ACE group. I'm just going to highlight here that whether a baby boy had a mother that was abused prepubertally or not, that if they had this adversity, that they were significantly different than the females, suggesting that, again, there's something about that prepubertal time point for moms and being a male fetus or a male baby that is impacting how you respond to stress. So that's pretty much what I'm going to talk about with respect to the perinatal work that we've been doing. And now I want to jump to midlife women, which is what I promised I would talk about. I just knew that there were people here that are interested in perinatal, so that's why I had to add it in there. It's important to know your audience. All right, so even though childhood abuse and neglect and adversity is a serious and very serious situation, and it kind of have these negative effects on health, I like to start out just giving people a little bit of levity, okay? To help you remember what part of the brain we're mostly focusing on in some of the research that I'm doing. So this is the game. What do these things have in common? I think everybody knows about this. So this is Maxine. She says, the older I get, the more I ask myself the really important questions, like, what did I come in here for? Now, who's had that experience multiple times? Okay. What has that got to do with the dorsolateral prefrontal cortex? How are these in common? Well, I think about this from the perspective of working memory. So basically, that's an executive function. You have to pay attention, you have to sustain attention. But a lot of times when you're thinking about what you need from another room, you're busy because you're about to go out, and then you walk from the room where you have the thought into a room that is completely different, even though it might be your bedroom and you've seen it 100,000 times. You have the thought in the other room, and now you're trying to keep it in mind when you're going into another space where it's different. And so it requires an intact prefrontal cortex. All right, so what does a plate of biscuits, buttermilk biscuits, have to do with the hippocampus? Okay. Well, I'm from North Carolina. I don't know if you can hear the accent at all, but I grew up making buttermilk biscuits. My family says I make the best buttermilk biscuits. The Denver Biscuit Company makes crappy biscuits compared to me, and I hardly ever find ones that I like better. So clearly I know how to make biscuits. If all of a sudden on a Saturday morning, I'm like, I'm going to make biscuits, and then I bring out the stuff and I forget the flour, or I stand there and go, how much of the baking soda am I putting in this? That would be concerning. So I use this as an example because that's a procedural memory. That's something that's embedded in my hippocampus. I know how to do it. And when you start losing your procedural memory and your ability to do things you've always been able to do, or know where to go when you're trying to get someplace, and those are things to be concerned about. So the reason I pull this apart is because most of the time when I give a lecture to people that are in midlife, they've all experienced a decline in their ability to do cognitively a lot of the things that they used to do. And that's okay. That's sort of normal aging. But we also know that aging is not the same for everybody, and that some people suffer cognitive aging or cognitive difficulties more than others. And again, that's where I focus on adverse childhood experiences. So for the clinicians in the group, or non-clinicians, I like to give a case of the kind of woman that got me interested in executive functioning in the perimenopause. and early, and particularly post-surgical menopause. So Kathy's a 49-year-old executive. She's in the late perimenopause. That's a period of time where women haven't had a period for at least 60 days. And she's worried about her memory. So again, memory is not, it's just kind of a loose term. Like what do we mean by memory? What do we mean by cognition? What are the domains that she's concerned about? She's also experiencing a lot of perimenopausal symptoms, like she's having hot flashes, night sweats, sleep disruption. She's moody, and yet it is her cognitive symptoms that has her most concern. That's why her gynecologist says, oh, you got to go see Neill. Okay. These symptoms are making her anxious about what others will think about her at work. I can't tell you how many times people say to me, I'm on rounds with the residents and they must think I'm an idiot. You know, I just can't remember or pull forth the information that I want to pull forth. And they're really embarrassed about it. She knows that Alzheimer's disease is more common among females, and she's particularly frightened because she has a mother with dementia. But her mother's 85, okay? We know that there are, 85 to 90, there's a high rate of some dementia in those individuals. So again, she's asking me, am I becoming demented like my mother? So then I ask her the questions, and invariably, this is what this woman says, and this is what all the women say. Well, I can't pay attention the way I used to. I get very distracted. I get bored in meetings. My mind wanders. And so I don't know why that's happening. And dear God, do not knock on my door while I'm trying to get work done, because a distraction will derail me. Forgetfulness, I can't remember the name. It's on the tip of my tongue. It takes me longer to get things done. I do have the word finding difficulties. And then one of the things that a lot of women will talk about is this decreased sort of, interest in doing things that are more mundane. So what kind of condition do our children, experience, and young adults experience that sounds similar to this? Okay, so it does sound like all of a sudden this woman is having onset of symptoms that are similar to ADHD. So I started really thinking about this prefrontal cortex and how could the hormonal changes that occur in the perimenopause. And I haven't really told you as much, but you probably already know that estradiol has a profound effect on numerous neurotransmitters, dopamine being one of them, and has very trophic effects on not only the prefrontal cortex, but also the hippocampus. So which part of the brain are we talking about here? You guys know this, dorsolateral prefrontal cortex. Now, the hippocampus is also impacted at perimenopause because we have seen that verbal memory can be impacted negatively, particularly for women who've undergone a surgical menopause, which is an abrupt removal of estradiol and all gonadal steroids. But the prefrontal cortex is what we're going to focus most on. So again, this is another case, and this is something I heard somebody who underwent surgical menopause say. When I was deciding at the age of 39 whether to undergo an oophorectomy to reduce my risk of cancer, my doctor told me I may have problems with my metabolic, heart, and bone health. No one told me that I would lose my mind. I wish I had waited. And we know that premature menopause before the age of 40, truthfully before the age of 45, infers greater risk for cognitive decline. And treatment with estradiol in this population, if they can use it, is helpful at reducing the decline, but it's not a panacea. It doesn't work as well as we would like. And so a lot of these women, this woman didn't have cancer, so she would have been somebody who could take estrogen. But if she had cancer, especially either breast or gynecologic cancer, she was not going to be in that situation. So we have a major gap with our colleagues in medical and GYN oncology, our breast cancer surgeons. The brain is not even a consideration and the risk-benefit discussion when it comes to surgical menopause. Again, this is still to this day a problem. And when I talk to GYN oncologists about this, they say, well, we need an algorithm. We need to know that this person's more likely to have the risk of X, Y, and Z, and we don't have those numbers. So I have set about trying to get this information out to as many people in the field as possible. So again, the female brain has to experience these hormonal gymnastics that occur over the whole lifespan. And during pregnancy, they're at very, very high levels of estradiol and progesterone, as well as cortisol, as well as CRH. And it just plummets as soon as you remove the placenta. And I am shocked sometimes at how well the female brain, this is why I think we're really, really a tough sex, is that our brain has to adjust to all of this all the time. And so I call it the fabulously flexible female brain. And I think we should really thank our brain for being so flexible. So what does that mean when it comes to different parts of the lifespan? Well, we know about 5% of young women will experience premenstrual dysphoric disorder at some point after their first menses. And we also know that women can have onset of PMDD after they deliver a baby, even if they didn't have it before. So there's some kind of priming effect on the central nervous system. We know that about up to 20%, but roughly more, 13% of women will experience a more clinical depression. That makes postpartum depression, and which often starts in the third trimester, it makes it the most common complication of being pregnant and delivering a child. It's not infection, it's not bleeding, it's postpartum depression. And that doesn't even include bipolar disorder, the onset of OCD in the postpartum period, or other anxiety disorders. And then we have up to 5-fold increased risk for depression in the perimenopause. And the majority of women experience symptoms that can have a negative impact on their quality of life. So again, despite the fact that the brain is having to be this flexible, it's not surprising that we're seeing these kind of mood disturbances, cognitive disturbances, et cetera, during these periods of hormonal change. So why focus on menopause? How many of you knew that 1.2 billion perimenopausal women are on this planet? It's a lot. So the sheer number should really strike you. This is what gets me. 6,000 women every single day become postmenopausal in the US alone. 6,000 women. I'm telling you, if it was 6,000 men with a problem and experience, and again, I'm not trying to be negative on the guys, I'm really not, but thank God our government is now realizing that we need to be focusing on women's health, particularly during midlife. The perimenopausal period is not a flash. It can be 8, even 10 years on average. And economically, it has a major impact in the United States. We lose $1.8 billion in lost work time related to menopause health issues. We're up, like I said, it's about a 2 to 5-fold increased risk for depression, and we'll talk a little bit more about that. Up to 62% report cognitive complaints. And particularly among Black females that are going through midlife, the average duration of their vasomotor symptoms is 10 years. Can you imagine having moderate to severe hot flashes for 10 years? Not pleasant. And then up to 60% report sleep difficulties. So I showed this slide to a group of ladies last week in Atlanta who were, it was kind of a fun luncheon fundraiser. And one of the ladies said to me after, she goes, 60% report sleep difficulties? She said, my whole table said, isn't it at 100%? And so I said, well, this is just what the numbers are. Maybe your table, it is 100%. All right. The thing about perimenopause and menopause and postmenopause is so interesting. As the age at final menstrual period on average in the US is around 51, but our life expectancy has increased from our 50s to 80 over the past 100 years. And who thinks that the brain adjusts to being no hormones? I mean, hypogonadal. How many people think the brain can adjust and evolve effectively in 100 years? It takes a lot longer than that. So we have to be thinking about midlife brain health and how factors such as age at final menstrual period, race and ethnicity, education, your health and your lifestyle, as well as early life adversity impacts brain health. So I'm going to talk about data from 3 different cohorts. One is the Penn of Varying Aging study. One was the Vassar Center survey, which was conducted in women who underwent a surgical or at least had removal of their ovaries. About a fourth of them, no, more than that, probably more like, but probably about 40% of them had cancer. And then we have something called the ACE working memory study. So how does ACE history impact women during the menopause? So the Penn of Varying Aging cohort was a prospective cohort that was culled in the 1990s when people used to pick up their landline. Do you guys remember having a landline and you actually picked it up? They recruited all of these women. Half the sample was Caucasian, half was African American, and you had to live in Philadelphia County. Everyone was enrolled as a premenopausal woman having regular menstrual cycles, and they were assessed over the course of about 14 years. And then they were followed through each of these menopause stages. So what we found is that there are women who have never had a major depressive episode, who experience a major depressive episode in the perimenopause and first few years post-menopause, and then it kind of tailors off. Then there are women who've had major depressive episodes that simply have a relapse in the perimenopause. And so I was asking Ellen Freeman, because I wasn't at Penn in the 1990s, so I was asking Ellen Freeman about, I said, do you think that we could go back and ask all those ladies about their adverse childhood experiences? And so we went back and asked women that were part of the study, and we already knew when they had their depression. And so of the women that had 2 or more ACEs, and again, this is where we did a sensitivity analysis to see if it mattered if it was 3 or 4 or 5, but at 2 or more ACEs, they had almost a 3-fold increased risk of having their very first episode in the perimenopause. So there have been resilient, well, I hate to use that term in some ways because they're still resilient, but they hadn't had a depression. And even though we know ACEs increase risk of depression, they hadn't had depression until they got into that hormonal fluctuation of the perimenopause. And it was like it unmasked that risk for them. So that got me really interested. And I have to go back. I'm sorry. I want to show you. We had already shown in the Penn of Varying Aging cohort, and again, this is more of a hippocampal task because it is about recall of words and learning of words. And you can see that if you say the premenopause is the baseline, that by the time they get to the postmenopause, their immediate recall of a list of words is worse. And the same is true for delayed recall, but you wind up seeing a significant difference earlier in the transition. So even in the early transition, obviously this is a more difficult task than this task. And so we said, okay, we've seen this in the whole cohort. And what about childhood adversity? How does that impact? Because some women did better every year because they did it for 14 years, so they knew the task and they improved. Some women stayed about the same, and then you had a decline in a number of women. So I was very curious about those who decline. So we started looking at those who underwent a natural as well as surgical menopause. And all of those women that I was talking about in the Penn of Varying Aging study, they all were naturally postmenopausal or perimenopausal. They did not undergo surgery. So again, how does this get under the skin and to lead these women to have worse cognitive functioning? So we again mined the Penn of Varying Aging cohort. Christina Metcalf is one of my mentees, a new assistant professor. She basically started to say, okay, let's look at immune markers because we have blood left over on all these women, and we know when they had, how they performed cognitively, and we know about their mood. So what was the impact of having 2 or more ACEs on these variables? She found that higher levels of IL-6, particularly in the late perimenopause, was seen in those with 2 or more ACEs. And again, you could say to yourself, well, isn't this been done before? I have to tell you, when she first started looking at this, we know very little about inflammatory changes across the menopause, whether you have ACEs or not. There's just again, there's a lot less fewer studies about midlife women. She also saw that higher levels of TNF alpha are associated with worse verbal memory performance, and this occurred over the menopause stages. And then she also saw that if women had more current life stress and higher levels of C-reactive protein, she showed that they had higher depression symptom scores. So again, this controls for BMI, race, and a number of other factors. So what this says to me is that the ACE is important in setting up your risk, but how healthy you are with respect to inflammation as you go through the perimenopause and postmenopause has an impact, and how much current life stress you have has an impact. And so the latter two things are modifiable. It's not modifiable that you had the ACEs to begin with, but if we know that these women are increased risk for some of these other factors like higher inflammation, maybe more current life stress, those are factors that we can modify once a woman is midlife. So the next study is with surgical menopause. And again, I told you earlier with that comment from the woman who underwent a surgical menopause, that the symptoms that these women experience are especially in the executive functioning domains, but sleep difficulties, mood difficulties, as well as cognitive difficulties is more exacerbated or pronounced. So this is a study, again, Mary Samuel, who is the biostatistician that I work with. She left Penn when I went to Colorado, and she is at Colorado with us now. And Susan Domchek is still at Penn. She's the head of what we call the Bassler Center to study BRCA. So she had a lot of women, and we used her listserv, 552 women. And all of these women had undergone an oophorectomy due to genetic risk for cancer. And basically, we gave them the average childhood experiences, the hospital anxiety and depression scale, because it's not my favorite, but that's what she likes. And so it's her cohort. So, it's a matter of collaboration. We measured executive functioning using the Brown Attention Deficit Disorder Scale, because while I was still at Yale, I started this work, and Tom Brown is ADHD specialist. And I basically, we contacted each other, and he said, are you seeing these symptoms in midlife women? I said, yeah. So we started working together, and I've used the BADS ever since. And then we gave objective measures of some aspects of executive functioning. One was sustained attention with something that's pretty boring. And then the very hard working memory task, which is the MBAC, and that's the 3-back. So it's a very difficult task. And basically, we wanted to look at the relationship between ACEs and executive functioning and the role of mood using the HADS on mediating the relationship between ACE and cognitive functioning. So we had roughly 350 women in the low ACE group and 202 in the high ACE group. And you could see that they were pretty similar with respect to age at oophorectomy, time since oophorectomy, hormonal use or time without hormones. History of cancer was a little higher in the low ACE group. This is selection bias because that's who comes in to get cancer screening, unfortunately. Previous hormone therapy was also higher in this group. Again, not terribly surprising. And the biggest, you can see here that this is a highly educated group, whether you're in the high ACE group or the low ACE group, because you had almost 90% of people with a graduate school or college grad degree. So this is a work that Sheila Shanmugam helped me with. She was my MSTP student back at Penn. And this shows results on the BADS questionnaire by ACE group. So the green bar it is green for you. The green is high ACE group, and this red is the low ACE group. And this is the total BADS score. So higher symptoms means that you have a higher score. That means that you have more symptoms and you're worse off. And you can see that in the total score, there's a highly significant difference between those in the high ACE group and the low ACE group. And then this instrument is broken down into various subcategories of executive functioning. Organization and activation for work. Again, that's that motivation to do something that might be kind of boring. Attention and concentration, alertness, effort, and processing speed. Managing affective interference. And this is a big problem for youth with ADHD. It's not really, never shows up that much for our ladies with in the midlife. And they just are not as severely affected in that sense. And then this is working memory and accessing recall. And you can see that in all but this managing affective interference, that those ladies in the highest group had significantly worse functioning in these areas. And again, this is a self-report. So let's look at what happens objectively, because again, people can say, well, it's subjective. What goes on, the objective testing is what really matters. And so how did they do objectively? So again, we had that sustained attention task and a working memory task. And here, actually having higher score is better. And you can see that both for sustained attention and working memory, our low ACE women with 0 or 1 ACEs perform better than women with 2 or more ACEs. And so we have objective as well as subjective measures showing that there's this impact of childhood adversity. Well, again, everybody says, well, mood symptoms can have, we know that if we have more depression and ACEs increases the risk of depression, like we showed before, these women may be suffering more from depression and anxiety. So we did a mediation analysis. Again, you can do that when you have 522 women, roughly equal in each group. And we did see that when it came to their self-report on the BADS, as well as their ability to perform the sustained attention task, that there was a significant mediation of mood. So basically what that means is that your ratings on your depression and anxiety scale, if they're higher, their ACE is associated with higher scores, but those higher scores also explain a portion of the ACE effect on cognition. And that shouldn't be surprising. But for me, what that says is clinically, if I've got a lady coming in like Kathy and complaining of moodiness, I'm going to delve into that because I want to say, okay, if I can help treat some of her depressive symptoms or anxiety symptoms, maybe I can at least improve what she thinks about her cognitive functioning and her sustained attention. The interesting thing is that when you get to the harder task of working memory, you do not see a mediation. Having lower mood or higher anxiety does not mediate the ACE effect. The ACE effect is directly for reasons that we haven't yet determined, because there are a lot of things that we didn't measure. I did not look at these ladies' inflammation. I didn't look at their sleep on this. So basically there's something else going on that is leading ACEs to affect working memory. And everybody asked me about chemotherapy. Was there an ACE interaction with chemotherapy history? And the answer was no. But chemotherapy did, if you had a history of chemotherapy, it was associated even years later, because on average, women were about 4 years since the oophorectomy, but the standard deviation was huge. So they could be 10 years post-oophorectomy. And what we found is that they still had a negative impact on sustained attention. So how many of you remember the pandemic? Is it a distant memory? No. So when you have junior people in your lab who need to get papers, then how do you take a pandemic that gives you lemons and make it into lemonade? You do online research. So my mentee, Christina Metcalf, who I talked about before, basically was doing a project where everybody was supposed to get a stress test in the lab. She recreated the Trier social stress test into a online administration. And she sent everybody, the little tubes to give their spit. She also sent everyone, a blood pressure cuff and all of this other stuff that we needed in order, and little ways to prick your finger so we could get cytokines. I'm not going to show you all of that because I don't want to steal her thunder. And she's just finished, so she's still working on some of the data analysis. But we did switch to online surveying because we were really interested in, okay, all of these women come to us when we advertise about executive functioning or memory. We get a lot of women, but they're all living around an academic medical center. And we wanted to get a sense of, just in the general population, what happens to executive functioning if you're premenopausal, perimenopausal, and then in the postmenopause group, we broke it down into a natural menopause or a surgical menopause. And what we found was remarkable. Again, we had almost 2,000 women in the study, 35 to 65. I have to give a shout out to Force, Facing a Risk of Cancer Empowered, as well as Research Match. And you can see here the numbers of people in each of these groups. You can see that the surgically postmenopausal women had their final menstrual period on average at age 41, whereas the natural menopausal women had their final menstrual period almost 10 years later. So again, that's a big difference. This is the Brown Attention Deficit Disorder Scale using premenopause as the standard, I guess you could say. And you can see here that there is a highly significant increase in executive functioning difficulty among perimenopausal women. This is attenuated a little bit in those that undergo a natural postmenopause, but look at our surgical menopausal ladies. And this is controlling for self-diagnosis or a diagnosis in the past, self-report of ADHD, as well as age and some other factors. So you can see here how this is very much different. Now, if we add sleep, self-disclosed insomnia, sleep problems, and then we use standard instruments to assess depression and anxiety, you can see the same pattern, but you can see a dampening of the increase. So that basically, if you control, again, for sleep, mood, and all of these factors, the menopause transition and the type of menopause is important, but it's dampened if you take care of those. So what, again, that says to me is that if somebody's having sleep difficulties, I'm going to want to treat those, and they're going to have a better sense of their own cognition. If we treat sleep, we treat mood. That to me is the clinical take-home message. So what are the brain effects of childhood diversity in postmenopausal women? So again, these are postmenopausal. These are women that were within 10 years of their final menstrual period. And we gave them what we call the MBAC task, which a lot of you know about. The hardest is the 3-back. So you're lying in a magnet, and when you see that image, you have to press the button when the image is the same image that you saw 3 places before. Now, it makes a lot of these women, they come out saying, I felt like a mental midget. And I always say to them, you know what, you did better than you thought. But in any case, it robustly activates the dorsolateral prefrontal cortex. And so we did bold imaging and basically assessed the dorsolateral prefrontal cortex. And we did a whole brain, but we also did this region of interest analysis, because this is what really showed up as being activationally different between women with high and low ACEs. So this was a sample of about 40 women, so it's not huge, but they underwent a very interesting paradigm. So it was 60 enrolled, 33 completers. Again, we looked at ACEs and the ACE effect. And again, my MSTP student was really instrumental in making all of this analysis and especially the imaging possible. So the study paradigm was quite complicated. And I keep saying I'm going to stop making very complicated study designs. And this is the last study I'm going to talk about. No, actually, one or two more. But in any case, they were randomized. They came in hypogonadal. They either had 2 or more or 0 or 1 ACEs. They either got an active tryptophan depletion or a sham depletion, because I was at that point very interested in the relationship between estradiol and serotonin and how childhood diversity could have a lasting impact on the serotonergic system. So they came in, they did these depletions and a hypogonadal state, underwent imaging in the afternoon, and then they were randomized to either 8 weeks of an estrogen patch at 100 micrograms, and then they were either given 8 weeks of placebo. Then we underwent this whole tryptophan and sham depletion again. So each woman had 3 test days, and it was quite something to keep women in this study. Again, these are the brain regions that are robustly activated while people are doing this, and you activate this region more, the harder the task is. So again, we extracted the data from this particular region. We showed that the more ACEs a person has, the more they have to activate that brain region in order to do well. You can see that here, that you have to activate more in order to perform better. This is what we find when we look at women in the hypogonadal state. This is our low ACE group. This is our high ACE group. Do they look similar? No, not at all. They don't look similar, and in the white, which is baseline. This is with the placebo, the sham depletion, and they don't really look the same in the with the serotonin depletion. What happens when we give them estrogen? So this is what I just showed you, a baseline hypogonadal. This is with placebo, not a whole lot different, not significantly different from this. But now let's see what estradiol does. Now, do they look the same? They do. Whether they got the sham depletion or the active depletion, they had a similar activation of that particular area of the brain that's important for being able to get this task correct. I like to look at this with the sham depletion. If you have to activate that brain region more to do just as well, because they did just as well, but you have to activate that brain region to do more, Danny Weinberger, who some of you probably know, would say this is an inefficiency model, that the brain is not working efficiently doing this working memory task in those ladies with higher levels of ACEs. And what I love is that this shows a very specific effect of estradiol, not in our low ACE women. You don't see any real significant change, but you do in the high ACE women. So this suggests to me that when we think, okay, estrogen's either great for everybody or it's bad for everybody, we know that that's not true. And we have to start looking at these individual factors. So what can we do about the fact that childhood diversity does, and I hope I've convinced you, that it does have these ongoing effects? Well, we could do something super radical, like prevent child abuse and neglect, okay? We talked about this at dinner. We could, as a culture, we know what we need to do. There's plenty of data about how we can improve parental stress. I mean, there was a study in North Carolina that was just really interesting about giving parents a livable wage. The child mental health improved. So probably there were better, the household was less averse. So again, we could do that. So how do we help Kathy? Does she have significant childhood adversity? I didn't say yes, but let's pretend that yes, that she had 3: parental separation, substance abuse in a parent, and emotional neglect. How is her health now? Does she have a reason to have greater inflammation? Is she, slogging the prefrontal cortex? Remember, she's an executive. She's slogging the prefrontal cortex day after day. I would guarantee you all of you are slogging your prefrontal cortex. I mean, let's just face it. Okay. I mean, I always say, like, if you went to the gym and you for 8 hours just did bicep curls, I mean, who would do that? I mean, seriously. I mean, even bodybuilders don't do that. So here you've got, you're going to have a fatigued muscle. You would say to yourself, oh, well, guess I overdid it in the gym. We don't go home and say, oh, I guess I overdid my prefrontal cortex exercises today. Yet we slog it day in and day out. So I would be wanting to talk to her about weight loss, improved diet, exercise, things that we know are helpful to the prefrontal cortex. And then if she was having sleep, she was having vasomotor symptoms, you got to treat those. She had low mood. How low? I mean, she was anxious. Is there anxiety, generalized anxiety, or is it just about the fact that her mother has dementia? So we have to really be thinking about all of these other symptoms as well. And then because these symptoms really struck a chord with me, like it was new onset executive functioning difficulty, and it sounded like ADHD, I basically I've done a series of studies, one with atomoxetine that I won't go into. It definitely seemed to help, but we went to doing 2 studies with lisdexamfetamine, the stimulant known as Vyvanse. And basically what we showed here, a greater reduction in total bad score when people got the, in the green, that was active, placebo minus baseline, I'm sorry. This is the orange bars are the active condition. And actually this is change from baseline. So greater decrease in overall score. And again, in all of the domains, really except not much difference when it comes to managing affective interference. But in primary attentional and cognitive and executive functioning issues, lisdexamfetamine was better than placebo. This was a double-blind placebo-controlled crossover study. So again, I told you I love complex study designs, and this one was, again, that. So everybody served as their own control. This is data from a group of women who underwent a surgical menopause. Their baseline BATH scores were in the 50s, which is significantly higher than what you see in women who are not surgically postmenopausal. And again, you can see that even within 3 weeks, and the ladies here were on 20 and 40 milligrams, they got up to 60 here, but within 3 weeks, we saw a separation from placebo. Again, in all the domains except for the effort and the affective interference. And we also saw that the letter MBAC, we used a letter MBAC this time, much greater improvement in the LDX group or the lisdexamfetamine group than placebo. So again, performance on a working memory test was aided with the medication. So in summary, average childhood experiences are common, and women are more likely to fall into the 4+ category than males. Even 2+ status is associated with risk for perimenopause onset of depression, executive functioning difficulties, and alterations in brain activation during working memory. And there are interventions available. And so I, again, had to switch to do the surgical menopause study with Vyvanse. I did it online. I recruited women all across the country. It didn't matter if you were a judge in Georgia or a school teacher in Rochester, New York. They all said the same thing. They said, my doctor has been working with me on this problem since I had my oophorectomy. They have no idea how to help me. Thank God somebody is doing this research. And I'm sitting there going, wow, this has to get out because doctors are afraid to use stimulants. I mean, they are by and large if you're a primary care doctor. And so we have to be able to show them that this kind of intervention can be significantly helpful. And then good news this week from our government. How many people saw this? That Biden basically has signed an executive order, President Biden has, announcing new actions to advance women's health research and innovation. There is a particular interest in midlife women, which thank goodness people are starting to care about midlife women. And about $12 billion to HRSA, NIH, other agencies. Think the NIH is going to get something like 200 million, which is not as much as I would like, but and he signed this on Monday. And this was a picture from Tracy Bale, who was invited to go to the White House and witness this. So next steps, we have to screen for ACEs in primary care, especially in GYN. Develop programs and interventions to identify high-risk women, particularly before they get to perimenopause. So helping make sure that they're as healthy as possible. We need to develop and adopt various interventions, as I've listed here. And we need to test more pharmacologic therapies that target the prefrontal cortex. I'm not satisfied with stopping with stimulants. I think we need to look at other medications that are easier to take, have less potential negative effects, and are less stigmatized if at all possible. All right, I have a lot of people to thank across the country and the various places I've been. I do highlight that both Mary Samuel and Tracy Bale are now at the University of Colorado. I am so grateful to have my team back again, and we've been really having a lot of fun together. Lots of different institutes. I've had R01s or P50s from 5 of the NIH institutes, as well as the Office of Research on Women's Health. And so without their support, we couldn't be doing this work. And now I'm going to stop.